As you know, endoscopic treatment plays a central role in the treatment of digestive diseases. The development from polypectomy as a resection method for gastrointestinal tumors to endoscopic mucosal resection, EMR, and endoscopic submucosal dissection, ESD, has now become a commonly performed procedure at many institutions. Compared to surgery, ESD is a non-invasive treatment that can resect almost all of the digestive tract, including the esophagus, stomach, duodenum, large intestine, and hypopharynx, and has gained wide acceptance. The movie on the left shows ESD of a large lesion that is mostly hidden in the appendix. Recently, the popular underwater ESD has become possible to resect lesions that were not resectable in the past. As you know, specimens resected by ESD, etc., are cut into strips after formalin fixation, paraffin embedded, thinly sliced, stained, and examined for pathological diagnosis. Although this method is very effective in evaluating and mapping the entire resected specimen, the evaluation by speculum is done only on the cross-section. This means that the tissue between cross-sections is essentially not evaluated. It is possible that there may be important findings in the tissue between these sections. Is there any way to evaluate between these cross-sections? Perhaps tissue transparency technology could be a solution to this problem. Among several reported tissue clearing techniques, we decided to use the lucid method developed by Dr. Onodera, which uses iodine-based solvents. The lucid method is characterized by the use of only safe reagents, easy processing, high transparency, short processing time, and low destructiveness to tissues. We first validated the lucid method using porcine gastrointestinal specimens. The image on the left shows the mucosa of a porcine stomach. You can see that the transparency increased in the following order: formalin-fixed specimens only, lucid-treated specimens, and lucid-treated specimens after paraffin embedding and deparaffinization. The depth of observation improved from about 100 micrometers to 700 micrometers in the esophagus, 500 micrometers in the stomach, and 600 micrometers in the large intestine, probably due to the removal of fat content, which is abundant in porcine specimens, by the deparaffinization step. This is an image of a stomach specimen observed with a confocal microscope. The left side shows the specimen imaged in horizontal section from deep to shallow, and the right side is a movie of the data constructed in 3D. As you can see, the structure of the glandular ducts can be confirmed, and on the data it is possible to insert a split plane in any direction. This is a movie of the large intestine and esophagus of a porcine, imaged in horizontal section as well, and constructed in 3D. In both cases, the surface structure, glandular duct structure, and vascular structure can be confirmed, and can be evaluated in any section plane. These images illustrate the specimens following the lucid transparency and imaging protocol, subsequently re-embedded in paraffin, and evaluated by He and Ki67 immunostaining. You can see that the structure and staining properties are preserved enough for normal evaluation. After these evaluations in porcines, we decided to evaluate them in human specimens. Initially, we applied the technique to a personal case involving a sessile serrated lesion. The markedly enlarged glandular orifice was clearly visualized, and the boundary region of the resected specimen was made transparent and imaged for 3D construction. As you can see, The gland duct structure continues to expand and meander behind the enlarged gland duct aperture. Based on these results, we have decided to expand the scope of evaluation to human specimens. This is the normal specimen flow. After formalin fixation, the excised specimens are divided, paraffin embedded, and thinly sliced for pathological evaluation. We have decided to observe the paraffin blocks that have been clinically evaluated and stored by lucid transparency after deparaffinization. Of course, the specimens that have been clarified and observed are returned to us paraffin embedded. Here are the results of the observation depth. As with the porcine specimen, you can see that the observation depth of the esophagus, stomach, duodenum, and large intestine has been greatly improved. In particular, the esophagus can be observed down to around 1,000 micrometers, allowing detailed observation of deep vascular structures. These are images of the stomach and large intestine taken by wide-area imaging using tiling. In the left stomach image, it is possible to observe the details of the surface structure. In the colon image on the right, an entire segmented section of an ESD specimen is imaged, in which the glandular duct structure and surrounding vascular structure can be recognized. This is a 3D constructed image of an ESD specimen of the esophagus. And although this is an ESD specimen of an LPM lesion, the dilated intrapapillary capillary loops in the lower left of the screen coming up from the depth and the structure of the large caliber vessel in the depth can also be observed. Above all, this is a split plane image that can be viewed in any direction. This is an image of a small Barrett's adenocarcinoma in the esophagogastric junction. And you can already see the improvement in the visibility of the blood vessels after processing with lucid. In summary, the advantages of tissue transparency using the lucid method include the ability to use paraffin blocks from previous endoscopic procedures, simplicity, safety, and low cost, the possibility of 3D construction, and above all, the ability to return to paraffin blocks for normal evaluation after the evaluation is complete. The most important of all is that the paraffin blocks can be returned to the paraffin blocks for normal evaluation. Last but not least, I would like to present a case study. A 67-year-old male. The patient had previously undergone curative ESD for 3 early-stage gastric carcinoma lesions. 3 years later, a CT scan revealed a lymph node subject in the small gastric antrum. At this point, we asked for pathological evaluation of previous specimens. and one lesion was found to have lymphatic invasion by deep incision. Additional surgery and chemotherapy were subsequently performed, but the patient eventually died 6 years after ESD as a result of BSC due to renal failure. This was a patient whom I had personally treated from the initial detection of early-stage cancer to ESD and subsequent follow-up, and it was a patient whom I was very attached to and regretted. It was right around that time that Dr. Onodera told me about lucid. At this point, we are not able to detect minute lymphatic invasion, but I think that the lucid method, which is capable of comprehensive evaluation as well as circumferential evaluation, may help reduce the number of such patients in the future. Thank you for your attention.